Thank you very much, and thank you for joining us for this session, which will be interesting because it's really asking the question about connected health. And we've got a panel here who've all been given 5 minutes to talk, but they've prepared about an hour and a half's talk each, so I'm going to have to be a bit strict. So look, I'm Robert Herkes. I'm the Chief Medical Officer of Ramsay Healthcare. My last substantive job was as the Chief Medical Officer for the Australian Commission for Safety and Quality in Healthcare, where we did quite a lot of work with the Digital Health Agency. And at a personal level, the ICU that I used to be the director of has had an electronic health record in that ICU since 1985 that ran on a big old mainframe that we weren't allowed to turn off because back in the day it was the backup for the Defence Signal Directorate's missile guidance system. So Prince Alfred had to keep this mainframe going in our ICU even though it wasn't being used for the ICU anymore because it was a backup for our Defence Department. So we've got a really interesting panel today. I'd like to first introduce Nathan Pinskier, who's a former Melbourne general practitioner and a board member of Peninsula Health. So he's played across primary care and hospital care and has been really instrumental within digital health and understands a lot of the tension points. Next, I'd like to introduce Brigadier Seidl, is a general occupational health within the Department of Defence and is a GP by background, trained in Western Australia, and is in the middle of implementing EHRs within Defence. Then Helen Almond, who's a researcher from Tasmania, looking at in the Australian Institute of Health Service Management and the College of Business and Economics at the University of Tasmania, looking at quality and safety and digital health within our system. And lastly, Professor Peter Sprivulis, who's the Chief Clinical Information Officer at the Department of Health in Western Australia and works as an emergency physician within Western Australia Country Health and used to do retrievals within New South Wales Health, so well experienced within our system. Full bios are available within the notes for this conference. If you shortly, at the end of little 5-minute vignettes, we're going to ask for questions from the audience and the online audience. So if you have questions, keep them for them. So first, I guess the question is, for us all, is why hasn't it worked? What's happened that's meant that delivering connected healthcare using digital technologies is so fraught? So, Peter, what are your thoughts?
Well, we do have some successes and we should be quite proud of those successes. I think the e-scripts is a classic one to use. And the way I like to think about it is in sort of 4 layers of barriers we have to break down to succeed in delivering connected healthcare. The first and the most trivial is technology. If you think about the e-scripts, the identifiers, QR codes, smartphones have been around for a long time. The next level is trying to connect those together in a coherent workflow. We've heard from the consumers this morning about how if we have clunky workflows, they can't adopt them. If doctors have clunky workflows, they won't either. So there's a bit more difficulty there, but as we saw with e-scripts, those problems were solved quite quickly. And so the thing is, well, why did it take so long when these things have been around for so long? And as we know, war, pestilence and famine are the great drivers of innovation, and it actually took the pandemic to bring those things together. But what other barriers had to be broken down? Well, the most important was probably the legal and regulatory barrier of allowing an electronic script to be the canonical version that was transmitted from a clinician to a pharmacist. So all states had to change legislation to do that. So that took some time. But I think there's another really important one that we failed to think about, and that is our financial and cultural drivers that we need. The federal government's got a lot of interesting levers it can use. Most health practitioners in all their forms probably paid 80 cents in the dollar from the federal government. Do we use those levers to support the changes in behaviour to make digital and connected healthcare reality? I actually think the addition of the Medicare rebate for telehealth was an important additional thing that saw e-scripts get adopted so rapidly. A GP could get paid for talking to a patient, understanding the problem, so they knew why they were prescribing and they felt confident in prescribing. So those 4 layers need to be broken down and thought about individually if we're going to connect other versions of healthcare.
Thank you very much. Thanks, Peter. So, Isaac, I believe the Department of Defence is implementing a clinical information system across the whole of your health services. How are you doing it? What are the benefits and what are the issues that you've had to overcome, and how have you overcome them?
Well, thanks, Robert. Can I just add my salute to the Gadigal people of the Eora Nation, and particularly their elders who teach us about leadership through their continuous stewardship of culture. A little bit of context about Defence. We like to see ourselves as a sort of separate jurisdiction in the context of the Australian healthcare system, because under the Defence regulation, the Commonwealth is required to provide me and the other 60,000 members of the ADF with the medical and dental care necessary to keep us fit for our duties. Our interpretation of that is that it is everything that I could get through Medicare and then some, based on an operational requirement, operational readiness. Defence of Australia requires our people to be at least as fit and usually fitter than the average person in the street. Delivering that care, has been a journey through, paper systems, through a first generation of Defence e-health system, previously known as JEDI, which, to the clinician is everything you don't want a digital health system to be, because it really was designed for Windows 3. And when you and I've been in there as a clinician, you're typing as you're consulting with the patient, you often have to pause and wait for the cursor to catch up to you. I kid you not. So we are in the process of upgrading that in partnership with industry, and it's very exciting partnership which will see a transformation of our systems to a connected, appropriately clinically governed primary care, allied health, and indeed also support us in managing that health system through developing insights to inform policy and improvements to service delivery. I think in sum that sort of describes what we've been talking about for the whole morning, which is clinical governance isn't something to be frightened of. It's not about government. It shouldn't be about rules. It should be about relationships. It should be about making it easier for people to do the right thing. And that means power to the patient agency. It means enabling clinical judgment rather than rules, writing policies that support all of the above through the entire journey. And I haven't talked to any of my notes, but I want to move on and listen to the other eminent members of the panel.
So,
Thanks.
Isaac, it sounds like, though, you have the advantage that you control the whole of the system, except for specialist consultations.
That is a great strength.
Is that fair to say?
A great strength, but also a huge vulnerability.
Why is it a vulnerability?
So, if I was to reflect on the part that makes people jealous when I describe our system is that it is a connected system from the general practitioner in primary care through a referral pathway to a specialist practitioner, secondary care in a hospital, rehabilitation, pharmaceuticals, any allied health or mental health add-ons, and I can connect the finance data to it, which means that I've got our own sort of ecosystem in which to do the insights play. The vulnerability is that if I'm here in Sydney and I need healthcare, I can wander into Victoria Barracks or Randwick Barracks or HMAS Cuttable and receive care, and my clinicians can see my records. But similarly, if I don't wander in there and there's a nefarious individual, they can do the same and see my records. And that goes to one of the key components of clinical governance and one of the themes of today, which is confidence. Confidence by our patients in our system, and similarly, confidence by our practitioners that the system is going to support them as well. Thirdly, the legal duty of confidence that we as health professionals have to our patients in common law.
Thank you very much, Isaac. So, Helen, as an academic with expertise in safety and quality, Are there themes that clinicians bring to you when they're implementing clinical information systems and electronic and digital systems that might cast some light on the issues with digitisation?
They are, and thank you for that question. Just to take you a little step back from there, as you said, I'm working as an academic now. I am a health professional, but working as an academic at the UTAS. And one of the most common themes I'm handed is, what's clinical governance got to do with me? That sits at a board level. I can't do this assessment. I can't do it. I work front-facing. I work in the Defence Forces. I work with correctional services. I work with paramedics. I have thousands of students going through, thanks to the Commission, the course at the moment. So it's really going back to what clinical governance means to those individuals, and in my situation, those learners, and in a research place, ensuring that I'm telling that story and that journey. And that goes all the way through to digital health and informatics. Oh, we don't use that system. We don't do it that way. I'm not responsible for that. Well, I believe we're all responsible. We're all responsible for our information, whoever we are, whatever person we are. When I take it back to the health professionals I actually work with as the learners, we have a scope of practice. We're bound by a scope of practice. Therefore, if we don't understand what clinical governance is, we should now be working in no-blame cultures, and that's a whole different conversation. But we should be working in those no-blame cultures where we're comfortable to actually say, I'm not sure how this system works. I'm not sure how you want something recorded. I'm not sure how to use that technology. So that people are really comfortable in that safety, that quality, and what clinical governance means, so that the person receiving the healthcare actually has the experience that they want. And we heard that earlier today. So I think that's the big message. I'm sure there'll be questions on that, but that's a big message from me. Thanks, Robert.
Thank you very much, Helen. Nathan, you're extraordinarily experienced in digital health solutions, both in general practice and as it moves across into the hospital setting. Both in digital health and in safety and quality for patient care. Can you tell us what you see as the opportunities moving forward for healthcare professionals in digital health technology, and what the dangers are from your point of view?
Thanks, Robert. I guess the starting point for me, and perhaps for some of us, is really understanding the journey. And the journey is a complex one, because we all have different expertises, different backgrounds, different experiences, different biases. And healthcare, we call it a healthcare system, but some would argue it's barely a system. It's just a series of parts that probably don't operate in a unified fashion. It just happens to work for most of us most of the time. And if you look at the background I come from as a healthcare professional, we're trained to be healthcare professionals. We're trained to use evidence-based medicine. We're trained to use standards in theory, and we're trained to work through a systemised format. We're supposed to understand the healthcare system. When you look at people who design widgets, and again, I think Louise picked up on this earlier, the fact that many widget designers don't understand what clinical governance is or what clinical care is. It's come from a personal experience, a personal bias, from a carer perspective. So they're coming at it from a different perspective. They're seeing the solution to a problem that may or may not exist. And that then starts a challenge around understanding what quality and safety is. And we all struggle in what quality and safety is. We have different definitions. I'd argue a lot of my colleagues don't understand clinical governance, clinical safety at all. And I've heard that recurring theme. I was trained by God to be God, therefore I am God. Of course I always work at my best. Of course, that's what I was trained to do. So if we're going to change the conversation, change the narrative, we need to be able to all get on the same page. And to do that, we need to work collaboratively, and we need to build teams of stakeholders, engage collectively and engage consistently. We need to do it over a long, long journey. Once we do that, we can then try and identify what is the problem we are trying to solve. And a lot of us get into solutions mode too easily. My engineering friends say, Nathan, stop it, get out of solutions mode, understand the problem. When you go into a room and you're listening to stakeholders, shut up. listen to the stakeholders. Don't give them your idea of what the world is. So if we're going to understand workflow, we need to work with the people who use the workflow. And we build systems that engage them, and that process is a continuous one of PDSA cycles. So we design the system, we have living laboratories, we bring people on a journey, and if we can do that effectively, we end up designing a solution that will work for them. We start with the end in mind, and we work with people. We don't train them, we educate them. We invest in change and adoption, because the biggest cost of the system is actually not investing in change and adoption. We have great technology, nobody knows how to use it, so it gets discarded. Your problem is not my solution. You're making it harder for me. Why are you putting barriers in front of me? We hear that over and over again. We've got some good examples in this country where we have worked effectively collaboratively. The CSIRO have run some really great programs in the primary care data set over the last few years where we've had broad stakeholder engagement and broad agreement. I think they're the key things. I probably would finish by saying, if you haven't seen the work that Peter Provenos has done in the United States from Cleveland Clinic, a really great example of how you can implement solutions. And what he says is when he walks into an ED and speaks to the people in ED about their problems, and then he speaks to hospital administration and others about their understanding of the problems, they are totally different. So top down, bottom up, middle out is a much better way of working and bringing people on a journey.
Thank you, Nathan. So, Peter, is the first problem that doctors do think they're God? Like Nathan just said?
I think there's some generational issues associated with that. There's also different forms of practice. Some of my best friends are cardiothoracic surgeons, you know.
Really? I didn't think you could be friends with a cardiothoracic surgeon.
Yeah. Look, I think that there is a
well, how do we overcome the God syndrome? Let's put it that way.
Yeah. I think that the advice of the engineers is there, and that is what we need to do is the word is probably co-design, and it's teaching people how to use those techniques and make them feel comfortable so that they can get out of their God mode and actually get into a room with the people that they are trying to serve and help, and listen to them at the same time.
Helen, do you have insights into this, having dealt with lots of aberrant doctors?
I think remembering that, to me, we're all leaders, and not saying it's not my job. That's a big thing that I hear time and time again. You know, it's not on my pay scale, it's not my job. It's actually taking that responsibility to say, we need bottom up, top down, middle out. We need that responsibility where people are comfortable to actually say, I want to be involved, I want to be a leader in this area, whoever you are. So to me, that's where I'd probably sit.
Okay, so we've got now time for questions from the audience. Are there any burning questions from the audience, or otherwise I'll have to think of some thorny thing to ask everyone?
Well, while you're thinking about it, I mean, here I'm in a uniform with a whole bunch of brass on.
Yeah.
The vast majority of our patients.
We don't have to question that you're God.
The vast majority. Well, this is our challenge in leadership, and the vast majority of our patients have no rank at all. How do we empower them to have agency in their healthcare from the very beginning, when traditionally we've beaten it out of them? Not literally, but you know, we say to we used to say to our recruits, "Don't you worry, we'll take care of your healthcare. You'll show up when we tell you to. You'll get an appointment with a specialist, and if you don't show up there, you know, you'll be charged. And then, by the way, if the specialist says that you have to have physio, you'll show up there, or there'll be consequences and so on." And then we wonder why, when our people transition back to civilian life, they don't know how to engage with the health system. So to me, you know, the digital health system that we're implementing needs to give back some of that agency, but at the same time our culture needs to change to go along with it.
Okay, so that sounds like in the military, a bit like paediatrics, everything's organised for you. And when you're a paediatric patient and you migrate to adult care, it's a completely different world and everyone gets lost. Is that how you see military health?
When we had to roll out COVID-19 vaccination, it was law that COVID-19 vaccination and flu vaccination went into the Australian Immunisation Register. our biggest problem was not compliance. Our biggest problem was the fact that many of our uniformed members had never had a Medicare number.
But that's because they're not allowed to.
Well, they are, but the culture says no. So we used to tell our people, as part of this process of beating agency out of them, that if you obtain healthcare outside of the system, that is fraud. And the reason for that was that we don't pay the Medicare levy because Section 49 says the Commonwealth will provide us with medical care. So they didn't bother. And then suddenly we needed to enter this into the register, and we didn't have the means to do it. So we partnered with DSS to have a hotline so that people could get a Medicare number, and the problem was solved. But there are barriers sometimes to digital health that we don't see in advance.
Excellent example of the IHI not being universal. Question from the floor.
Yeah, it's a lot easier to ask the question than to answer
Certainly
it.
is.
My question is about scale. Absolutely endorse the idea of co-design. It's the only way we're going to be successful in these things. But for example, we're sitting in New South Wales, 17 local health districts. What you might do in Broken Hill is different from what you might do in Westmead. How do you get that balance right between having co-design and supporting adoption and ownership versus not having to do this thing 17 times?
So I'll ask Nathan and then Peter, because both of you have got
Peter, it's a
hospital
great question,
experience.
because in the time I spent with Nita and having the multiple stakeholder consultations as you did, you'd get 100,000 different views. And how do you synthesise those down into 1 or 2 or 3 working models that are going to work for most people? I think part of it is bringing people on the journey to say, well, look, you might have a way of doing that, and we understand it, and that's quite appropriate or may not be appropriate. But in digital health, sometimes some things have to change. So how do we bring people on that change adoption curve, and we do it with them, not to them? I think that's the single biggest challenge. And I gave Robin an example of e-prescriptions. E-prescriptions are fantastic. I don't think anyone disagrees, and we've wanted them for years. But you look at the culture of paper scripts and why so many specialists use paper scripts. A script is also the way of ending a consultation. I grab my script pad, I say, Peter, right, you need one of these 3 times a day, take it before breakfast, after lunch, whatever, and I walk to the door, I open the door, I walk you out. How do I do that in an e-world with a computer? I can't walk the computer to the door. So we have to understand the context of the workflow, why people are doing certain things, and what can we do to support them in the transition. So the resistance may be more about, this is the way I've always done it. There may be a better way, but until we work through the workflow implications, we're not going to get there. So it's a nuanced conversation over time, not a simple one.
Peter?
We recently had Helen Bevan come over from the NHS to WA Health, and I think what's really important is thinking about your governance processes rather than having lots of little flowers sort of growing up in 15 different districts. Having the entity and the governance and the communication methods in place so that you are identifying which are the good ideas, and you have the processes to share those across to the other agencies that otherwise wouldn't have the capacity to do that. And there's a whole range of channels that are needed to do that. These days there's a lot of social media that can be used, there's collaborative methods, but it has to be within a governance architecture which is purposeful in wanting to ensure that you do get harmonisation, you do identify the right designs, and you do have, you resource the process of spreading those across the others. It doesn't happen by accident.
Thank you, Peter. There's an online question, Helen, here about, we've had a lot of talk about clinical governance, but how do we get our technical colleagues and our IT colleagues to buy into clinical governance? Should we?
Thank you. Yes, I do think we should be. I think all the way from the top down through to the person who's front-facing in healthcare should be aware of clinical governance and delivering a health and safety. I think, and it follows on from the last question as well, it is about co-design, but understanding that that change happens slowly, and the co-design can change within different local health districts or within different states, jurisdictions, however we choose to actually phrase it. And it's actually working with those people, because that's what co-design actually is finding out what that person needs. We have our standards, we know what the standards are. It's how do we apply those standards? How do we apply that clinical governance within that setting? And that can be digital health, because that's equally clinical governance, just as mental health, whatever area it may be. It's actually bringing everybody on board. So what matters as much to a clinician matters as much to the technical person they are working with. And co-design means bringing all those people in. And hopefully in my learning and my research that I'm actually articulating that to people. It doesn't matter who you are in health, clinical governance and digital health is on your agenda.
Okay, thank you, Helen. A question up the back.
Thanks very much. So there's no denying that co-designing, bringing everyone on the journey throughout the pathway is the only way to go. But I'm really interested to hear, the clock is ticking with people reverting, or clinicians reverting back to potentially old ways of doing things because the crisis need of COVID has ended. Their workloads are busier than ever. Any thoughts on how do we address this differently? We need to educate, we need to do the change management, whether you call it education, training. How do we actually bridge that gap between technology being available and actually embedding behaviours ongoing?
And that sort of segues with one of the questions here on the chat line, asking, there are lots of standards, when are we going to enforce the standards as opposed to just try and do it softly? Nathan, what do you reckon?
Look, I think it's a great question. People will default back to the thing that they're most comfortable with. So if you force them to do things like upload millions of shared health summaries to My Health Record and there's no benefit, the moment it ceases to be enforced, they'll stop doing it because there's no use for them. It has to be usable, useful and safe for them to do. So it's got to be something they want to do. I think it's a much broader question actually around the way we structure healthcare service delivery, and that goes back to the whole strengthening of Medicare. If I look in my sector, particularly in general practice, it's broken because we have so many rigid rules around funding that we're not actually allowed to work collaboratively and get the right people to do the right work. So if the clinician has to pop in to see Mrs. Smith in order to say hello, for the nurse to do the dressing or to give the vaccine so that you get funded, well, they're going to drop something else on the way. What we need to do is look at the way we fund the system and have the right people with the right scope of practice doing the right work. And if we can do that, then people will start to focus on the things that are meaningful to them.
Isaac, is it any different in the military?
Yeah, we're not constrained by that. I don't have to comply with, the doctor has to give the blessing for this to happen. If it's more appropriate for a patient to go direct to the physio when they've rolled their ankle, then that's where they go. If it's more appropriate for someone who has a mental health vulnerability to see a psychologist first, then that's the first door. But I think the problem is cultural. Example, at the beginning of the pandemic, we were very quick to introduce telehealth. In fact, before Medicare did it, we already had plans in place in partnership initially with the Australian Psychological Society. We wrote the policy, it's rusted into our policy that telehealth is a thing. And yet just last week, I had a conversation with some people at our Joint Operations Command who were saying, telehealth isn't working. And when I asked why, it wasn't that telehealth was a bad thing, it was that the psychologists had written their own rule that said you had to drive to Sydney to sit in a room to receive the telehealth. Well, I mean, what the? So this was a very small group of individuals who had heavier weighting in what they said, and it just simply takes some leadership to identify when these vulnerabilities occur and drive through them, and continue to reinforce the message.
Another set of gods. Very quick question because we've got 1 minute left.
Yeah, Brigadier, just from the perspective of defence, you have a closed system, and when you develop a new strategy, does that closed system give you the advantage of being able to really be at the leaders in evaluating cost benefit of all these new strategies, because you can measure it from seeing the doctor to prescribing to hospitalisation. Did a strategy reduce hospitalisation? Are you in fact the leaders in this field, and how do you share that with the rest of us?
In the short time we've got, I wish we were, and that's aspirational. Work as imagined versus work as done. What I tell my colleagues in Canberra is we have the potential to be the canary in the coal mine on things like low-value care. The example is that we had an issue in South Queensland with instrumented spinal surgery. Spinal fusions in South Queensland represented 80% of the spinal fusions conducted on any Defence Force members Australia-wide. We did some deep dives, identified the clinicians involved, and had some conversations with them. That has now changed. But could we not have wider conversations across the health system about low-value care, what we need to lean, what we need to limit, and most importantly, when we need to listen to our patients more?
Okay, that's a great theme to end on. Listen to our patients more. Thank you everyone for coming today. Thank you for your questions, and please join me in thanking the panel.